Sridhar for giving me this opportunity. Originally supposed to be a live case, so because whatever reasons, we're just showing one of our cases that we have recorded recently. This patient is a 66-year-old female who presented to us with unstable angina, and she had a good LV function. She was a diabetic and a hypertensive, and the angiogram showed triple vessel disease. First, let me play the angiogram. I'm just putting it in loop so that you have enough time to do the films. You can see that the angiogram shows a relatively short left main and an osteoproximal critical lesion in the LAD, and there is visible calcium in the coronary artery. The circumflex has mild disease. The ostium doesn't have too much disease. Distal circumflex has got mild diffuse disease. And the RCA, again, similarly has proximal critical disease. Again, there is fluoroscopically visible calcium, the entire length of the coronary artery. Okay, we did, any comments on the angiogram?
Can we discuss so how Archier will go for this case? 66-year-old patient, diabetes with triple vessel disease, calcified. Can you go back also? Can we have opinion, please, Dr. Arun?
Yeah. So this is a calcified. Probably the ostium of the LAD involving the left main is calcified. So I'll image it. There is a mid disease also. So I'll image that also. Mid segment of LAD is borderline. So I'll take a pullback from LAD to left main. Maybe I'm planning for a crossover. It's a non-dominant circumflex. So I'll go for a crossover stent after the lesion modification, depending on my IVUS finding, whatever. And RCA, I couldn't see. Where is RCA? Again, RCA, the imaging, and it looks really calcified, maybe a rota to RCA. Cutting balloon, followed by that one stent.
First RCA, then first go for RCA, then LAD.
So, Dr. Akasaka, what's your opinion?
I think the key issue in this case is the LCX modifies, right? If we can identify not so calcium or disease, and we have enough lumen area, we can do the crossover single stent strategy. That is the key issue to avoid the complicated procedure.
That's why I think we have a separate run from the circumflex of the imaging catheter. We have to look at the circumflex ostium. Is there a calcium sitting exactly diametrically opposite to the circumflex ostium? That can create problems for the circumflex ostium. Otherwise, we can go with a smooth sailing with a crossover stent.
So everybody agrees that this patient needs some kind of a calcium debulking strategy, right? So what strategy would you think would be your first choice in this case?
Actually, always imaging. See, when we do the left main bifurcation, L6 assessment, block burden, luminal area, landing zones, we have to see LAD landing zones, LM, distal LM is involved or not. And after that, where exactly you want to land, that is very important. If the calcium, IVUS image shows severe calcific nodule, based upon that we'll decide. So, if there is a concentric or deep calcium, based upon that. But I personally feel this calcium, any device works well, but if really eccentric calcium is there, I am worried about the AVL or balloon-based strategies. Eccentric calcium more dangerous. When the eccentric calcium is there, calcium nodule is there, always do the plaque modification adequately with the orbital, a bigger vessel, definitely. Or else you can do the wide bias C and the rota can be done. That's it.
I think very nice inputs there from the panel, and this is the run, there's the pre-PCI run and the RCA, and we chose to do the RCA first. I'll let the entire run play. As the run and then I can invite some comments from the panel.
Yeah. After looking at the IVUS, the vessel is wide, roomy actually. There is no critical stenosis or a nodular protrusion where taking the hardware should be a difficult task for the operator. So I think, and the wire bias is not very favorable. It's in the center. So I have to go with an IVL, appropriate sizing of an IVL in this case. Do an IVL followed by the NC balloon or a cutting balloon and put a stent.
I think he may require multiple gadgets because it's a long segment calcium. Various morphologies of calcium. IVUS may not tell a full things about the morphology of the calcium, but there is calcific nodules. There is 360-degree arc calcium. There are areas where there is 260-degree arc calcium. We do not know the exact thickness of the calcium. The balloon may go through. I fully agree with Dr. Arun Mohanty that we may require something to crack the calcium. So it is not the atherectomy alone. We have to crack the calcium for a full device expansion. So cracking may require either IVL or OPN. It depends upon the pocket strength of the patient also. Then whether we require an additional orbital atherectomy or, as Dr. Mohanty said, the wire bias is not that great. It's a big vessel. If I want to go for an atherectomy device, I may opt for an orbital atherectomy in this case because it's a long segment. A single device can do the entire thing.
Yeah, I think I appreciate all the inputs. The area that I test is about 1.4 millimeters, and I'm positive that an IVL, upfront IVL wouldn't have worked in this case. So my strategy was that I will do an initial rotablation. Okay, let's see the IVUS run from the LADL. Let's see it.
So you tackled left system first?
Actually, right.
Right.
So to continue with what I was trying to say is that in this there are different types of calcium. There is superficial as well as deep calcium. We can infer the presence of deep calcium from the fact that at many places there is absence of reverberation artifacts, and then it's quite diffusely disease. And the narrowest area is 1.4, 1.5. And I thought IVL upfront will not work in this patient. So my initial strategy, as would be in most situations, is that to do a rotablation. So the initial plan was to do a rotablation and followed by cutting balloon, because there are also areas where there is fibrocalcific plaque. There's a mixed plaque. There's significant fibrosis also in some places. So I thought a cutting balloon also would be required. So this is the way we did the procedure. We just crossed with the run-through wire, and then we exchanged with the rotafloppy wire, and we went with a 1.5 millimeter rotabur, and it didn't cross very easily. The rotabur did not cross very easily. And then, subsequently, and when we were crossing, there was a significant RPM drop. So ultimately, it did cross some patience and diligence, and this is how it looked after the rotablation. But this is a post-rota IVUS.
You see, if you ask me, except for in the steel images, except for the third image, rota hasn't touched the calcium in any of the segments.
There are multiple cracks. Actually, there are multiple cracks at multiple levels.
Only thing which I can see, there is a reverberation around the catheter. There is a place where rota has touched the calcium. I don't think rota has done anything.
You can see the loop. It has caused cracks in at least 2-3 places, or 2-3 levels. There's a crack here. There's a crack here.
Here, where was in
There's a crack here.
favorable bias?
This is just post-rota.
No, actually, there are adequate fractures. You can see very clear cracks. It's an adequately modified block.
Yes.
So if you put a stent will expand very nicely.
Yeah. I think I was also tempted to do the same thing, because I thought we got adequate cracks. But I thought that at some places, there was a 180-degree uninterrupted arc, more than 180-degree uninterrupted arc. And I also felt that I didn't achieve a very good MLA in some places. So I thought that I would use an IVL now. So you can see with the IVL, there's a significant waste there. And so the proof of the pudding lies in the eating. So now we use the IVL. It's a 3.5 12 millimeter shortwave C2 IVL. And I had to give entire 120 pulses were exhausted for the RC. Exhausted the entire 120 pulses for the RC. And you can see that the waste actually slowly disappears when you go up to 6 atmospheres. And this is the IVL. This is the IVUS post-IVL. So we do it systematically. I mean, it takes a lot of time, but we do it patiently because we want to demonstrate how each.
IVL plus an atherectomy device seems to be the best strategy or the most balanced strategy in this case. The rota used a 1.5 bar
1.5.
and did not escalate further.
No.
But I think before going for IVL, though that's a great option, but after you have done a rota and we saw some favorable wire bias in 1 or 2, 3 places, there were some
If you can freeze that, I'll show you. Just stop it.
I can't stop.
It's a loop.
Here.
Yeah.
This is the area where rota has done something polishing. Rest of the area is away from rota actually.
Will you consider orbital atherectomy in this case over rota ablation? Because it's a pretty big vessel. There is nodule. Wire bias is not that great, and there is long segment where you would like to have some atherectomy of the entire calcific segment, the entire sheet of calcium.
When we have very long lesions, my personal preference is to use root ablation because orbital takes a hell of a lot of time, and because of the time, though orbital is reported to have lesser slow flow, as the time of ablation increases, I think the incidence of slow flow also increases with orbital. That has been our experience.
The maximum time you can use is 5 minutes.
Yeah, so because it's a very long segment and a long segment disease, I think root ablation would still be my first preference in this case. In any case, I think we got a reasonably good debulking with both with rotatripsy. But still, I felt that at some places I needed a bigger lumen gain because there is some fibrosis also. So then I used a Wolverine cutting balloon. So this is a rotatripsy. So we've demonstrated all the 3 technologies here. I mean, interestingly,
Now we have softened the superficial area, the vessel superficial calcium. You have softened, you produce
I differ because rota itself showed nice fractures, nice cuts. So the imaging criteria went to upsize the or escalate the modification strategy. If the thickness is more than 0.5 mm, if we don't see any cracks anywhere, then that is the indication for upsizing the bar or going with IVL everything. But I could see the wonderful cuts even with rota. But I personally feel even without IVL also, this case could have been done.
So I strongly feel, I think we should take comments of Ajay sir.
I think the nice thing is that there's so many experts on stage and everybody has spoken of a different strategy. I think the bottom line is that we shouldn't deliver a stent and we are sure that it can be expanded perfectly.
Yes.
And instead of escalating to a cutting balloon, simple thing is to try and use an NC balloon. I mean, this is the fellow's course. This is what we're going to teach them. You just use an NC balloon and interrogate it at 10 millimeter segments. Use the same stent enhancement features that you have, and that's going to tell you whether you need to escalate it or, you can then use the cutting balloon where you need. You can possibly go back even before the IVL, probably that is what we would have done in our lab. IVUS has a limitation that it doesn't tell you the thickness and the cracks. There will always be, there are 4 experts, there will always be 3.5 opinions between them as per the location and the extent of the cracks. I think all we need to demonstrate is expansion. When you demonstrate expansion with a 1:1 non-compliant balloon, you can go ahead and stent. If you feel it's not expanded, that's the place where you need to focus the attention.
I agree with Dr. Kasturi. You see, there were reverberations in the tightest part. That means the thicker part has been shaved off.
Yeah.
It has become now thin. Now easily it can be cracked with NC balloon. You see, there was enough indication that rota has done a good job at the tightest part. I agree, there was some part where rota didn't touch, but the tightest part, you see the thicker part has been shaved. That's why we see reverberations. Reverberations in these, that thicker part has been shaved off, the surface has become smooth. Now, NC balloon in high pressure can be
After that, there is a luminal gain.
there's a luminal gain also.
Is there, and once after rota, NC balloon dilatation
Could have been done. Could have been done.
It's a mandatory step.
So
See that waste is not there.
3 things for fellows. So you're using rota, always check with the imaging whether how much you have modified, and before when you're doing imaging, just see whether your wire bias is in favor or not. And after you have done rota, going for second modification device, always do and palpate palpate it with maybe the cutting balloon or with a normal NC balloon.
The wrong message should not go, that we have to use all the device in every case, like we have to do this.
Yes, that's very important.
IVL, we have to cutting balloon,
and best
everything,
thing-
because this can be done a single aorta plus a NC balloon.
And best thing that you showed was, you were checking your modification. And the message should be, before putting a stent in a calcified lesion, always confirm your modification. That is the most important thing. And if you are confused in IVUS, you are not able to localize, as I said, that my vessel is well prepared or not, always palpate it with the balloon. Take a 1:1 NC balloon, go up to the nominal pressure or subnominal, just see whether your balloon is expanding well or not. Then vessel is prepared for putting a stent.
Yes, at the moment in the randomized study, there are no significant difference between the
Modified balloon and
rotablator or orbiter versus modified balloon technique, right? That is the one key, right? And also, when we try to do the ablation by using a rotor or orbiter, the position of the calcium and wire bias is very important. If the the calcium is the inner side of the RCA, orbiter pullback manner is so effective. But the outside, I think the rotablator might be always go past through the outer curve of the wire. And that is the very important. Sometimes the calcium is very complex, so one procedure might be not enough, I think. It's but depend on the calcium deposition. And also, after, yes, so in this case it might be very difficult, but yeah, after ablation of the calcium, you can use high pressure ballooning to make a crack. And if it is enough, you can put a stent.
So I totally agree, sir. The reason why I opted for IVL is because I did find on the IVUS, I was quite convinced that there were areas where there was an uninterrupted more than 180-degree arc of calcium. There are places where the calcium was cracked quite handsomely. There were places where there was more than 180-degree arc. So normally when we do this complex intervention, we go with the maximal strategy, because there is no point in doing a half-hearted and coming back, there's no point de-escalating and re-escalating. We go with the maximal strategy that is most likely to work. And then we did the Wolverine, and I'll show you the pictures after the Wolverine. You can see it's even better.
I beg your pardon. The criteria of severity is not 180, it's 270 degree. Both in OCT as well as you see IVUS criteria. You do scoring more than 270 degrees is a severe calcium.
Yeah,
180 is a mild moderate calcium.
I agree. That is de novo when we start the case. So, but once we do a debulking strategy, we want cuts in preferably all quadrants. That's why you get a uniform expansion of the stent. So 270 degrees is okay when you de novo decide on the debulking strategy. But once you've done a debulking, you still have more than 180-degree arc of uninterrupted calcium. I think you want a more cut there. You want to cut in every quadrant if preferable.
I think
So this is the post-cutting balloon. So here I got some medial dissection, and then I got much bigger lumen. And then I went and deployed the stent. And you can see the very uniformly, beautifully expanded stent. And of course, I post-dilated the stent with a non-compliant balloon. And this is the final, slightly faster pullback.
Was guide deep inside the we could not see the ostium of RCA actually. We could not see the ostium of RCA. I felt guide was slightly deep inside.
No. This is a very fast pullback. This is a 4 millimeter per second pullback. And there we go. So that's why it immediately comes to the guide. So this is your final result angiographically. I think it's quite good. Everybody agrees.
So most importantly, whatever tools you are
Ostium
using,
has been imaged and it's fine. Ostium
the most important message is whatever tools you are using to modify calcium, the MSS should be good and MSS should be appropriate for the vessel.
Yes. So whatever works best is the best.
Actually, DISRUPT study, one of the landmark study, post-IVL studies did not show any fracture in 35% of the patients. It only altered the compliance. They demonstrated micro-CT analysis, micro-fractures. So it altered the compliance. So IVL is exemption if you give the IVL, but usually even DISRUPT study, did not show any difference between eccentric calcium nodule. Compared to the superficial
Final
concentric,
MSc.
same result. But clinically, in our practice, everybody's practice, eccentric calcium still it will not work that well. Calcium nodule. The balloon rupture is more likely. But orbital and definitely eccentric. Eccentric calcium, if you go with the balloon-based strategy, the dissection, intramural hematoma, extension, very common. Sometimes patient may land in a big problem. So that is an adequate block modification prior to the procedure is ideal thing. But I think you are showing LED also.
Do you have time?
A little bit fast.
Can we use a 1.5 millimeter burr?
Here, rota will be excellent because there is a nodule sitting on the ostium actually. Yeah. So I hope the rota will be appropriate choice for this lesion.
So obviously we had some difficulty in negotiating the tightest portion, and with a higher RPM we negotiated that. There was a significant RPM drop. The post-rota IVUS.
Here see how much reverberation are there, and this is a real rota pollis of the nodule which is causing reverberation.
Again, this portion just went by. I thought that we didn't get a multi-quadrant crack. So again, I went with another IVL. This time we used the Indian IVL, the Mason Admiral. And after that, we did one more. So we got much better cuts, much better calcium modification. You can see here where there was uninterrupted calcium after the rota. You can see in the right lower panel. You can see it's the much more multi-quadrant cuts, much better calcium modification. And then we used a Wolverine balloon. Our practice is to use a cutting balloon or a scoring balloon post-rota because it allows us to not use very high pressures. In fact, if you look traditional teaching about rota is that just don't go with very high pressures post-rota. So we are much more comfortable using a cutting balloon or a scoring balloon at nominal pressure post-rota. I think that gives you a much better lesion modification and much better lumen gain.
If you are using imaging, if you are sizing it on one size down, particularly cutting balloon, you can go up to high pressure also.
Yes.
So you can go up to 1820 also.
Yes, yes, we can go. Especially the scoring balloon is a non-compliant balloon.
Yeah.
So it also helps us modify the lesion much better. So this is the stent, and it's a 50 millimeter stent. It's a 2.75 Nagomi stent. This can go up to 4.5. That's the reason why we picked this stent. And post-dilatation, the final result. That's an excellent result. So the final angiographic result.
And what was done with the which size balloon? What? Proximal optimization.
Yes.
Size of the balloon.
Did you image the circumflex also?
I don't remember. I think it must have been a 5 or a 4.5. I think it's a 4.5.
Did you image the circumflex ostium? What is your strategy? You do a kissing balloon or?
Yes, we did an IVUS run in the circumflex before we did any intervention in the LAD. The ostium of the circumflex was more than 5 millimeters square. And there was distal diffuse disease, but the ostium was more than 5. So the strategy was to go with a single stent crossover strategy.
So again for fellows,
Yeah.
main size of the stent should not be. Before putting stent in the left main, you should know the expansion of your stent. Because in my opinion, this left main was close to 4.55. So we should always know that your 2.75 can go up to 5. I don't think so. Any 2.75 can go to, because in IVUS we may not see the stent fracture, and in these cases you can have
Nagomi 2.75 goes up to 4.5.
The most important.
The reason we chose Nagomi was because of that. Nagomi specifically goes up to 4.5.
The most important thing is going up to 4.5 is not important. Delamination of the stent, loss of drug.
So polymer
loss of polymer breakage. The drug kinetic gets disturbed. So this is what is important. So going from 2.75 to 5 is not. You can have one cross-link fracture or something. It's not causing an event, but the drug loss will cause restenosis. That's important that stent must have a bench test like Megatron, which has a in vivo test of.
Megatron has even the Nagomi has a lot of bench
Yeah,
testing.
yeah.
The Nagomi
So
has a lot of bench.
this is one important thing. And second thing, try to achieve at least more than 10 millimeter square for left main MSA. If it is a large left main, so it should be according to size. More than 10, your event rates are really low. If it is 12, 13, then it's practically nil. So that is what is important. The third thing, while pulling back the guide catheter, the stent deformation is very high in left main position. So you must pay attention to the stent struts at the ostium of left main. It's 9% or 10%. In 1 in 10, you will have a stent deformity. Unless until you are paying attention, if a large stent deformity, it leads to event. So these are few points one should take care.
One should always give time for such a long stent to get deflated before pulling it, because again, that's again precursor of longitudinal stent deformation. And you won't see it on the angio, and you may miss it on the IVUS if you are not looking for it. So in our lab, the final thing that we do is maybe the final thing that when we are coming out is POT. Because we have learned from October study that USD, unintended
Stent deformation.
out of the left main, last thing do POT and come out. That is what we, because when your guide will hit the proximal edge of the stent.
Always slide the guide over the balloon when we deflate and take the balloon out. That's the best strategy.
Yeah.
So thank you very much for a nice demonstration. Thank you. Complex calcified cases of different, using different calcifying modifier tools. And thank you very much.